nice to see everyone. My name is Elizabeth LeVay, and just to kind of give you a frame of reference from where my presentation is coming from, I am a board certified women's health clinical specialist. I'm a physical therapist by training, and so my job is primarily in academia. I teach at Bellarmine University, but I do clinical practice here in Louisville. And this topic really came about because I've had a lot of patients who have fallen in the bathroom. And I feel like as some patients age, that the bathroom can become a scary place for people. And it really shouldn't be. I think there's a lot of strategies that we can do to help ourselves and help our patients decrease the risk of falling or getting injured in a bathroom. So that's what I'll be talking about today. Okay, there we go. So what we'll be doing is just describing the anatomy and the function of the pelvic floor, discuss age-related changes that affect pelvic floor function and toileting, identify normal bowel and bladder habits, and explain ways to reduce bathroom-related falls, and summarize the benefit of pelvic floor physical therapy. And forgive me because I'm not really sure exactly who's in my audience, but I'll probably say you or your patients a lot because this can certainly be helpful to patients if you're coming from a clinical arena, but this can be helpful for yourself as well. So just to give you a little background about why do we care about bathroom-related falls? Well, 80% of falls at home occur in the bathroom. And that's a lot. If you think about it, the bathroom can really be one of the most dangerous spots in our home. And the chance of having a bathroom-related fall or injury actually increases with age. So the older we get, the more likely we are to fall in the bathroom. And when we have a fall, it's typically the head or the neck that is the most common area to injure in the bathroom. And that's pretty scary because I think as we all know, the head and the neck control a lot of our body. So to have a fall with, who knows what else, plus a potentially head or brain injury, that can cause some long-term lasting effects from that fall. And of those bathroom-related falls, about 14% of people are hospitalized, usually from complications. And then 17% of people experience a fracture. And from my understanding, if I remember correctly, this article that these stats came from, I don't think they were looking specifically at people with osteoporosis. This is just in the general public. So when we factor in things like decreased bone mineral density or having other comorbidities like osteoporosis on top of this, I would even, guess to say that some of these numbers, particularly the chance of a fracture, could increase. So this, again, these stats are just kind of like a general picture. But either way, that's a pretty significant amount of people who are falling in the bathroom or are injuring themselves from a bathroom-related fall. So a lot of people are not super familiar with the pelvic floor and what it does and how the heck is this related to falls. But this is my area of expertise. So this may be a review for some, but if it's not, I'll kind of go into detail a little bit about what the pelvic floor is and what it does. But the pelvic floor is really the musculature that is sitting between the sitting bones. So these are the muscles that we sit on every day that are underneath our glute muscles. And if you can kind of look at the diagrams, we have someone who is anatomically male next to someone who is anatomically female. And the musculature is pretty similar. You'll see the shape is fairly similar. the muscles themselves are almost identical, which is kind of surprising to a lot of people because, our genitals are so different, but our musculature is very similar. And that being said, they work very similarly. So our pelvic floor, one of its main functions is for support and stability, right? It helps support the underside of our pelvis or our pelvic bones. And it really connects really like our upper extremities from our lower extremities and kind of gives that stability in addition to our abdominals and hips and back muscles. It also has a sexual function. So these are the muscles that help to maintain an erection or have an orgasm. And then lastly, and this is really kind of the connection to where we're going with today, is it has a sphincteric function. So it is really these muscles along with I would say it's really these muscles that are responsible for helping to maintain continence, meaning that if we want to empty our bladder or bowels, these muscles will allow us to do so. But when we don't want to, accidentally pee ourselves, these are the muscles that help maintain that continence. And we'll talk a little bit more about these muscles and kind of what happens as we age, what's normal, what is not normal of these muscles. But I think it's a good idea just to have kind of a basic understanding of that these muscles exist. And a huge part of their job is to help keep us continent. Okay. So as we age, there are quite a bit of different things that happen to our body that are normal or typical. And first, there are hormonal changes. So we have a decrease in estrogen, testosterone, insulin-like growth factor, and vitamin D. And we tend to have an increase in cortisol, parathyroid hormone, and follicle stimulating hormone. And really big picture, what does this mean is that all of these hormones impact bone formation is what I should say, or the process of bone formation. So some of these help build bone up, some of it help break bone down and restart that process. But there are going to be changes in our bone formation due to some of these hormonal changes. And then additionally, if we're talking about individuals who are anatomically female, that decrease in estrogen or potentially decrease in testosterone in men is going to change our pelvic floor function. So, particularly in women, when we have decreased estrogen in our body, that leads to fragility or like a thinness or subsequent weakness of our pelvic floor muscles, which may dispose us to incontinence. And then we also have age-related loss of muscle and strength, which, as we age, there are a lot of different physiological things that happen in muscle, and that usually results in a subsequent decrease in strength. Or, it gets harder to stay strong as we age, particularly if we don't have this good foundation of strength. And that decrease muscle mass and decreased strength has been associated with slower gait speed, which means we walk slower. And that's not the case of every single person who ages, but you tend to see a decrease in gait speed as we age. And then what does that mean in terms of going to the bathroom? Well, we don't get to the bathroom as quickly as we used to. And that may result in issues with incontinence. So related to incontinence, aging just in general is a risk factor for incontinence. There's a lot of different risk factors for incontinence, and there's a lot of reasons why someone might have incontinence. But by definition, we consider incontinence as any unintentional loss of urine or stool, really of any amount. So people will, or my patients will say, well, yeah, I leak urine, but it's just kind of like the normal amount. And I'm like, any amount is not normal. So no matter your age. So aging is a risk factor, but that doesn't mean it's normal. So if you're having any kind of leakage of urine or stool, particularly if it interferes with your life, that could be a problem. And we'll talk about how to address some of that later. But incontinence is not normal, but it is very common. So it affects over 300 million people worldwide. It is 3 times more prevalent in women. We are just lucky because of our anatomy. It looks a little bit different than people who are biologically men. And it's also one of the leading causes of individuals having to go into like a skilled type of nursing facility or things like incontinence. So all of these are going to be some age-related changes that you'll see. So I want to talk a little bit about what is normal bladder and bowel function, because a lot of people don't know this, and there's not a lot of good education about what is normal, because I need to know if I'm abnormal, right? So the bladder can hold about 450 to 550 milliliters of urine. And depending on what type of literature you look at, you might see a little bit bigger number, but let's just say a rough estimate of around 500 milliliters. And the bladder will get the first sensation of filling around 100 to 250 milliliters. So it's a little bit full, and the brain will get a signal from the stretch receptors in the bladder that say, I think something's going on. Okay. So then the bladder continues to fill at about 200 to 300 milliliters, and we get that desire to void. So the stretch receptors in our bladder send a signal to our brain, and our brain says, I think I need to use the bathroom. And we can override that signal. We can say, not now, or yeah, let's go ahead and go to the bathroom if everything about our nervous system is intact. And then around 350 to 560. So, I mean, the bladder can be really full or almost overflowing, and then we'll get that strong desire to void that it's almost impossible to ignore. And then typically, most people with a kind of normal functioning bladder will void 5 to 8 times a day. And that varies based on, things like fluid and medication use. But on average, somebody should be urinating once every 2 to 4 hours during the waking hours. So when you're awake, once every roughly 2 to 4 hours. And then at night, someone should be waking up one time or less, again, dependent on a lot of different factors, medication use, fluid intake. But, if a patient is waking up multiple times at night to urinate, that's a sign that they may have pelvic floor dysfunction or kind of something going on with the urinary system. It should never be difficult to urinate. It shouldn't be painful. It should always feel like you're fully empty. It shouldn't feel like, you go urinate and then you stand up and then you got to go again. That's a sign of incomplete emptying. But the bladder is never completely empty. We have a post-void residual of around 50 milliliters. And this may be more in people who have neurological diagnoses, but it's never completely empty. But you shouldn't feel like you go to urinate and then you have to come back and urinate, within that 2 to 4 hours. So this is really what it looks like to have a normal bladder function. So we talked a little bit about incontinence, and in general, incontinence is a problem, or essentially a urinary system problem. So any unintentional amount of urine, that could be a couple drops, that could be a gush of urine, that could be complete saturation of clothing. Incontinence is a risk factor for falls. And the research shows that women who have incontinence have a higher incidence of osteoporotic fractures. So I mentioned that kind of impact or the layering of comorbidities. So, we have, if you have a patient or yourself has incontinence, you have osteoporosis as well. Not only are you more likely to fall, but you're more likely to injure yourself and have a fracture if you were to fall. And then anticholinergic use is also associated with risk of falls. So anticholinergics are kind of one of the go-to drug classes that people get put on for things like overactive bladder or urinary urge incontinence. So that kind of incontinence that says, when I go to the bathroom, I got to go right now or I'm going to have an accident. So people get often placed on anticholinergics, which have been shown to be fairly successful in their management. However, you have an increased risk of falls. So there's side effects of these medications that we have to weigh when we're, that's something the patient needs to discuss with their physician or whoever prescribed the medication. Especially if you have things like a history of falls, whether the anticholinergic use is worth it, or should we go towards some of the behavioral modifications that have no real side effects that we'll talk about in just a moment. So now we'll talk about bowel health, and this is probably talked about maybe even less than bladder health. But as far as normal bowel health, most people have bowel movements that 3 times a day to 3 times a week. And really that, whether you're at 3 times a day or 3 times a week, we're going to talk a little bit more about like what does your consistency and volume of stool look like? And we'll show you on the next slide what that should look like. But you should have good consistency of your stool and good volume. If you're going 3 times a day, but you're having like little tiny poos, you might not be emptying all the way. So that 3 times a day is actually not normal. You're just not emptying. Or we can have that other end of the spectrum where you're like, I'm so bloated, I'm so gassy, I just can't go to the bathroom that much. And, you're more at that 3 times a week or even less. That's when we're starting to talk about constipation. But we would roughly consider 3 times a day to 3 times a week normal. I try to have most of my patients going like once a day if I can. But normal transit time is 24 to 72 hours. So that's the time someone eats something to when it exits the body. And the easiest way and kind of the old-fashioned way to know what your transit time is you eat some corn and see, note when you eat it and note when it comes out. And that will give you a rough estimate of your transit time. So if your transit time is less than 24 hours, it's not necessarily a bad thing. You might just have a really fast gut, and that may mean you're the person who's going to the bathroom more than once a day, and that's okay. But if your transit time is less than 72 hours, you may have a slow gut, and that can cause a buildup of stool in the colon, and you might be, more of that 3 times a week or not even 3 times a week. And, that can cause its own set of problems. So we have our first perception or sensation that our rectum is filling when there's about 15 to 35 milliliters of stool in the rectum. You'll say, I think something's going on, but I'm not even really thinking about it that much at this point. And we get our first desire to defecate or have a bowel movement at about 100 to 150 milliliters of stool in the rectum. And at that point, we say, hey, I need to go to the bathroom, but the brain says, is it a socially acceptable time? If it is, we can go. And if it's not a socially acceptable time to have a bowel movement, maybe we're driving, maybe we're in a meeting, maybe you're in this conference and you're like, I don't want to miss anything, so I'm going to delay it and just ignore it. We can do that at this point. If our rectum is full of 100 to 150 milliliters of stool. But our maximum tolerance is going to be around 200 to roughly 300 milliliters of stool in the rectum before we really have to go, and we can't suppress that urge anymore. At that point, we're almost having an accident. So these are your bowel norms, and we'll talk right here about consistency. So I talked a little bit about consistency, and we judge stool consistency by the Bristol stool chart. This is it's been around for a long time. Our stool can range anywhere from type 1, where we've got those, everybody calls them like the little rabbit pellets, but they're hard, they're difficult to pass, can be uncomfortable, all the way down to type 7, which is entirely liquid. So there are no solid pieces of stool with this. And we're really looking for stool consistency, we're looking for a type 4. That's the most ideal, where it's soft like a sausage or snake. It's easy to pass. Some people say it looks like a banana because there shouldn't really be any cracks on the surface. But this is what we're looking for. And that's not to say every day is going to look like that, because our bowel consistency, our stool consistency is heavily influenced by things like hydration, our diet. So particularly if you're someone who has food sensitivities, and if you're like me, sometimes I don't always pay attention to them. So we're looking for a type 4. And type 4 is easy to pass, right? We can fully empty. We feel like, this kind of sounds silly to say, but if you've ever just had like a really good poop, and you're like, yes, that was it. It's probably type 4, because you're fully empty. It was easy to pass. So when I work with patients, we're trying to get our stool consistency to be a type 4. And that may, there's a lot of different things we can do to impact our stool consistency, but some of that is hydration, and we'll talk about that in a little bit. So how are bowel problems related to falls? Well, constipation, meaning we have those little rabbit pellets, we're straining to empty, we don't feel like we're emptying all the way. That is thought to be a precursor to incontinence. So what happens is when we're constipated, our colon fills up with poo, and that full colon presses on the bladder. And that is thought to be a precursor to incontinence. And based on what the research says, we know that people who have both bowel and urinary incontinence, meaning they leak urine and they leak stool unintentionally, have a twofold higher risk of falls. So if you or your patients are suffering from this, you have a much higher likelihood of falling. And then lastly, there's been research about the association between chronic constipation, meaning this constipation is not like a day thing. This has been going on for, 3+ months, and diarrhea and frailty. And frailty is kind of like this umbrella term, but really we're looking at this decreased function of multiple physiological body systems. And people who are considered to have frailty have a higher risk of mortality, heightened risk of hospitalizations. They have increased risk of falls, and they also have an increased use of using long-term care facilities. So having chronic constipation, in and of itself, especially if that is intermixed with diarrhea, that can cause falls just in and of itself. So being able to manage some of these bowel and bladder problems is essentially, the hope is that it would decrease the chance for falls in the long run and some of these other issues that can result. So we kind of talked about pelvic floor function, and bladder norms, bowel norms, and kind of the issues that can arise when there are bowel and bladder issues. But how do we prevent those? Because there's a lot of good evidence to say that we can, or patients can, we have a lot of strategies that can help reduce bowel and bladder symptoms, and hopefully thus then decrease the chance of falls or injury. So we'll go on just a moment to talk about bladder irritants, bad habits that people develop, the nervous system and its impact on bladder and bowel health, urge suppression techniques, toileting posture, environmental modifications, and physical therapy. So we'll talk about this, and I'm trying to not go too fast. So if I am, please stop me, but we will definitely have time for questions at the end. So let's talk about bladder irritants. This is pretty well studied in that there are many different foods, drinks, and I would say like additives and supplements that make the bladder angry. And I'm going to focus primarily on bladder health in this kind of last section, because if we're looking at people who have bowel problems, I would say incontinence, fecal incontinence or urinary incontinence, there's a higher prevalence of urinary incontinence. So we'll talk more about urinary, but a lot of it applies to, bowel as well. But things like coffee, soda, alcohol, tomatoes, hot and spicy food, chocolate, caffeine, citrus drinks or juices, MSG, anything that's high acidity or artificial sweeteners, and I'd even say artificial colors. Things like red dye can be really irritating to people. So not every single one of these things is going to irritate every person. So, you may be someone who coffee really, really bothers you. And you notice that after you have your morning coffee, you are constantly running to the bathroom. And that's not ideal when we're talking about decreasing our fall risk. If we're having to run to the bathroom or hurry to the bathroom because we're worried we're going to have an accident after we drank all this coffee. But maybe perhaps spicy food doesn't bother you at all. That could be the case. I once had a patient who I remember she told me I ate 2 bites of pineapple and that was it for me. I was so flared up. Um, it was a huge trigger for her. So what I would recommend you or your patients do is you start doing a diary of your symptoms. I'll usually have patients do it between, 2 or 3 days, all day, all night. You don't have to actually wake up every hour to document, but, in the morning, make sure you write what happened at night. But you're writing basically when you urinate, what time specifically, whether it was a small, medium, or large urination. So a couple seconds, or like 10 seconds, or like 20 seconds. And then whether or not you had an accident, if that's something that is common for you, whether you had a leak, whether it was a small leak, a medium leak, or it was so bad that you had to change your clothes. And then I will have my patients document their fluid intake. So how much did you drink? What was it? Was it coffee? Was it water? And then what they ate as well, because we can look at it together and we can start to identify patterns and say, yeah, it really seems like coffee is a huge trigger for you. And I keep on going back to coffee because it's a really big trigger for people. And if that's the case, what are we going to do about it? Can we switch to half calf? Is it really the acid that's bothering you? So they do make some low acidity coffees, because I don't know if you're like me, but I cannot give up my coffee. I just don't think I could do it. It would be hard. Or do we combine your morning coffee with a morning water as well? So what can we do to combat some of this? And if you're someone who you're like, yes, I know this is me, I have a lot of bladder irritants, then you can, especially if you know that acid is what bothers you. So like the spicy food, tomatoes, citrusy things. They also make an over-the-counter supplement called Prelief. It's Prelief. That I want to say it's an acid reducer, but not like a Tums. Okay, this is not like a Tums. This is specifically meant for people who've got that, oh my gosh, I gotta go right now. Ask your doctor if that would be appropriate for you to take. It's over the counter. Recommending medication is not within physical therapist's scope of practice. So that's not something I can recommend, but I say talk to your doctor about it. Maybe they don't even know it exists, and see if this would be appropriate for you if you have these symptoms from, some of these foods or drinks. And then if that doesn't work, a lot of times we just try to cut it out. So you may just say, I just can't have pineapple. Or if I really, really, really love pineapple, I'm going to have it, but I'm going to stay at home and be in my environment so that if I have to run to the bathroom, it's a known area. I've got people to help me, that kind of thing. And like I said, these are more bladder irritants. The bowels can be irritated by totally different things. So, and again, it's trial and error. What are your symptoms like? Some people are more irritated by red meats or fatty foods or dairy. So trying to make a symptom log, and seeing, what do my symptoms correlate where I'm having to like rush to the bathroom. Because again, it's that rushing to the bathroom that puts us at an increased risk for falls. So these are irritants. There's lots of strategies that we have to try to minimize or avoid their irritation of our bladder. So next we'll talk about bad habits, because I would be willing to bet that every person who is here today has developed a bad habit of some sort, because these are habits that we develop oftentimes, not all of them, oftentimes in childhood. And they put us at risk for pelvic floor problems. And the first is just in case peeing, or we call it jicking in the pelvic floor world. And I'm sure everyone here has been told at some point, you better go pee just in case. We heard that as a kid, right? Better go pee just in case, because we're about to go to the store, or we're about to get in the car for a while. And from childhood, someone would tell us we need to go try, just go try. And these are habits that can carry on into adulthood, that now maybe I go pee just in case before bed, or just in case before a shower, or just in case before my long commute to work. And what happens is we start to go more frequently than we really need to. And the bladder is very trainable. So the bladder says, I need to go more often now. And if I can't go, if a toilet is not near, then I am like panicking. So these just in case pees can actually be problematic. So if you have children, just realize this. It can be problematic and turn into bad habits as adults. But if you don't have to pee, don't go. That's my biggest recommendation. So we really need to stay on that once every 2 to 4 waking hours, because we don't want to start going every 2 hours and then it becomes every 1 hour, and then the bladder is just very confused. And then next is hovering over a toilet. I've been guilty of this, in the past as well. Typically, my patients say this is during, public restrooms. They don't want to sit on the public toilet. So that's when I'm like, put down your layers of toilet paper and sit on the toilet, because your pelvic floor muscles that we talked about earlier that sit on the bottom of your sitting bones, they need to relax for you to urinate. And if you're hovering and you're kind of like tensing your butt or your legs, and you're not fully relaxed, if you're kind of semi squatting, you're going to have a harder time usually emptying your bladder. And this can lead to, lots of different pelvic floor problems. So make sure you sit completely on the toilet, and we'll talk in just a moment about, the proper posture to do that in. And then I have patients who do Kegels while they're peeing, or if you're not sure what a Kegel is, that's just a pelvic floor squeeze. And patients will say, I'm really proud, Dr. LeVay, I did my exercises that you taught me, but I did them over the toilet. And I say, no, not over the toilet, because when you are trying to urinate, right, you should be relaxed. So do not try to test your pelvic floor strength by squeezing your muscles over a toilet, right? If you have been given pelvic floor strengthening exercises by a physical therapist or some kind of healthcare provider, that should not be done over a toilet. And then next is straining. So we've probably all been there, where at some point in our lives we have been constipated, and that may be just a one-time thing or an intermittent thing. But straining or pushing to either empty your bladder or bowels, what happens are when we're straining our pelvic floor muscles, they're kind of like a bowl, right? If we push or strain, they elongate or stretch out. And when our muscles stretch out, they get weak. And then weak muscles can lead to incontinence. So you kind of see it's like this circle of, the chain of bad events. So if we're pushing or straining to empty our bladder, then that's going to cause some long-term, risk of incontinence. And then again, increased risk of incontinence means we could have more chance of falls. And then last is fluid restriction. I would say most patients that I work with are at baseline very dehydrated, and that can actually cause pelvic floor, well, bladder or bowel issues. So when we're dehydrated, our stool tends to be, lumpy, cracky, hard, more towards that Bristol stool chart 1 or 2. But also, when we withhold fluid, our urine gets more concentrated, and that concentrated urine can irritate the bladder. So patients will say, well, I'm just really not drinking any because I'm trying not to have to go all the time, but it's not helping. And I'm like, no, it's not helping because now your urine is like bright yellow and your bladder is angry. So it's actually better to if you are someone who restricts their fluid or have a patient, gradually try to increase their fluid back to normal. And you've probably all heard that the kind of recommendation is half your body weight in fluid ounces of water. There's not, at least from what I can find, a ton of evidence behind those numbers. If you try to find like the original article that said that, I've never found it. So, I think that's just kind of what's been adopted. So really, I just use the pee color test. It should be like a light straw to a clearish color. If it's not, then we got to change our fluid intake. Um, I do struggle with patients who say, well, I hate water. I got to add my little flavoring packets, but we find out that those flavoring packets can be irritating, especially if it's like a pink, lemonade, for example, it can be really irritating. So if you have a patient or you yourself don't like water, I would say try it at different temperatures. Um, that's kind of one of the biggest things I tell people is, well, if you don't like lukewarm water or cool water, try it with ice. Or if the ice bothers your teeth, try it room temperature. So try to experiment with something like that before you go adding additives and flavors. But, you know, um, it's a give and take. But just know that restricting fluid can actually cause some of the problems that patients are trying to avoid. So next I want to talk a little bit about the nervous system, because I kind of mentioned, what is the process of urinating, but the physiology is it's kind of complex. But what you need to know is when the bladder expands, there are stretch receptors in the bladder that send a signal to the brain that says, I am filling up. Pay attention to me. And the brain has to make a conscious decision. It has to say, okay, I recognize that my bladder is filling and I need to assess whether it's a good time to go or not. It's a socially appropriate time to go. So really the brain is essentially responsible for initiating going to the bathroom. So that being said, if our brain is not functioning properly, some days I feel like mine's not, but if our brain is not functioning properly, then we are going to have issues with bowel and bladder function. And I don't just mean people who have brain injuries or neurological conditions. There is an association between urinary symptoms and anxiety, stress, and depression. Some of that I think is because, bowel and bladder issues are such kind of like a taboo topic, that, it feels shameful for a lot of patients to talk about them or admit that they have these issues or seek help. And that can be very isolating, and can contribute to some of these anxiety, stress, and depression. And when we're looking at bowel and bladder problems, it's really treating these issues as a multi-systems process. So yes, when I see a patient, we look at your hydration, we look at your diet, we look at your habits, I look at your muscles, but I also want to know what's going on in your brain. And that's not, sometimes we need outside practitioners to help us. Sometimes I do refer my patients to psychologists or psychiatrists because it's a much bigger issue than what I can deal with. But we often do, we work on diaphragmatic breathing. We work on calming the nervous system. We work on meditation. Pretty much all of my patients get some kind of meditation or visual imagery where I have them in a safe space calmly relax and visualize what it would look like to get to the bathroom safely and in a controlled way. There's not a ton of evidence or just like literature in general on the kind of connection between these. But anecdotally, I tend to see people who have urinary and bowel issues really, we know that they have, there's like higher risk for some of psychological disorders, but like, what do we do about it, especially as physical therapists? So all of my patients get some kind of brain retraining of some sort. So the next thing I want to talk about is urge suppression. And this can be done for urinary problems or bowel problems. So just kind of keep that in mind, but I'm going to speak to it as if we're talking about urinary problems. And urge suppression has some of the highest level of evidence in research. So it's a grade A evidence, meaning we're pretty certain based on the research that this has moderate to substantial benefit with very little harm. Again, going back to like the medication use, yes, medication use can be beneficial for patients, but this is actually rated a little bit higher because there's no risk. So if a patient comes to me and says, Elizabeth, I am having to run to the bathroom and I can barely make it sometimes, or sometimes I don't make it. And that's really scary because I'm afraid that if I'm hurrying, I'm going to trip and fall. This is the person you want to use this for. So whenever a person has a urge to urinate, and maybe this is you right now, you've been sitting on this call for a while and you're like, I kind of need to go. Well, try this with me. This is the process I would take you through. So you're going to sit or stand quietly. This means like if you're out in the store or if you're out at a family gathering, if you can sit down, if you can't, I want you to just stand quietly and kind of put yourself in a calm yourself. Okay. We're not going to go run to the bathroom right away because what that does is it puts our nervous system into more of a flight or fight. It's like, gotta go now. And you're kind of like getting anxious about it. Where do I get to a toilet? I'm in a public space. I don't know where a toilet is. And then we spiral, right? We're trying to avoid the spiral. So we sit or stand quietly. And then if you're sitting, if you feel like it's a socially appropriate time to do so, you can put pressure to the perineum or just kind of underneath those sitting bones on the pelvic floor and just put some pressure there. And what you're going to do is you're going to do maybe 3 to 5 really strong pelvic floor contractions or squeezes. So 3 to 5 strong squeezes where you squeeze, let go, squeeze, let go, squeeze, let go, maybe 3 to 5 times. And then you're going to take a few deep breaths, right? You're going to breathe through your belly and just say, and you're going to do 3 to 5 of those. And it's important to be positive. So give yourself some positive affirmations. You can say to yourself, okay, I've got this. I'm going to be fine. There's no reason to spiral. Okay, whatever positive affirmations you need. And one of the most beneficial things I've seen is actually number 6 is then you got to distract yourself because, again, we're not trying to run to the bathroom. We're trying to calm the urge down. We're trying to get it off the cliff. And I had a lady come to me who had urinary urge problems. And I told her, well, when I have patients distract themselves, I usually have them pick a category, like any category you want. And I want you to name things in that category. And she's like, well, how about farm animals? And I said, cool. All right, let's talk about farm animals. So she did her squeezes. She did her deep breath. She's like, I got this. And then she would say, cow. And then she'd take another deep breath. Horse. And then she started naming slowly and controlled every farm animal, that she could think of. And that is to take her mind off of the urge. And then the 7th step, if need be, is to do some heel raises. So kind of come up on your toes. You can be sitting, you can be standing, kind of do a couple heel raises. And then the idea is that your urge would be from, almost spiraling out of control to a more reasonable amount. And you can slowly and safely walk to the bathroom. Now, let's say you're out in public and you don't know where the nearest bathroom is, or maybe you're driving. I hate this when I'm driving and I'm like, the key in the door, like, you're like, oh, I just turned down my road and oh my gosh, now I need to pee. Just go through this process again. So maybe it's gotten a little better and you're like, okay, but now I'm turning up my driveway and oh my gosh, the urge is back. Start with step one again. Put some pressure, more pelvic floor contractions, take some deep breaths, start your distraction technique again. Maybe it's a different category. It doesn't matter. The idea is to take your mind off of that really strong urge, because we don't want you to rush to the bathroom in an unsafe manner, particularly if you are at risk for falls. This is something that, I mean, everyone alive is going to have well, most people, I should say. There's a couple unique instances, but pretty much everyone is always going to have a urinary urge at some point in their lives that is not in the most convenient spot. So if I were here with you right now and I had the urge to urinate, I would probably do this. You wouldn't see me do it, but I would do some squeezes, I would do some deep breaths, and I would try to get that urge to subside until this presentation was over and I could go. So this works for everyone. You don't have to just use this, if you have incontinence or don't, it doesn't matter. And it's just as helpful for bowel urgency. So as long as you don't have diarrhea, that's a different story. But if you're someone who is like, I kind of have to go to the bathroom, but it's not an appropriate time to go, or I got to make it to this public restroom, the pelvic floor muscles control your bladder and your bowels. So if you have that urgency to have a bowel movement, do the exact same steps so that you can safely make it to the bathroom. And this is a technique I utilize for people who have gotten into really bad habits where they go pee like every 45 minutes or an hour. When that urge comes, I'm having them go through this routine. And it can be really scary at first because people say, I'm afraid I'm going to have an accident. And I say, I know it's scary in the beginning. When you first start doing this, just try it in your house, try it in a space that feels safe, because the bladder, you can retrain it pretty well. And like I said, there's really high evidence for this working, but it does take some commitment. Yeah, urge suppression, very successful technique and can help you get to the bathroom safely. So I said we talk about toileting posture. So now that we know that we can't hover and that we have to sit on the toilet, there is a proper position to do that. So if you look on the left side of the screen with the X, a lot of people sit on the toilet just like this. What I will say is more and more people, especially with aging, have elevated toilet seats. I see this really frequently. And an elevated toilet seat, while helpful to help you get up off the toilet, it's not good for helping your muscles relax and allowing you to empty. So what we would prefer to see is someone like on the picture on the right, where the person's knees are above the level of their hips. And the easiest way is to get some kind of step stool to put under the feet that you can, just put every time you want to go to the bathroom. So the most, and I do not get any money from Squatty Potty, so I have no association with them, but that's kind of the common brand name is the Squatty Potty. You can buy them anywhere, Amazon has them. I think maybe even like Target has them nowadays. So they're even portable, like Squatty Potties you can take on vacation. But if you don't have a Squatty Potty, you can just find a step stool or a really big book or a box. If you're traveling, a really good thing to use is a trash can. So just turn a trash can on its side, pop your feet up there, like if you're in a hotel or something. But what this does is when we have our knees above the level of our hips, it allows those pelvic floor muscles to be in a more relaxed state, which is what we want when we're trying to empty. When we're trying to empty our bladder or our bowels, it does not matter. This is really going to help those muscles relax better to empty fully. And you're like, why do you keep talking about emptying fully? Well, again, it goes back to that. If I go to the bathroom and I'm not empty, I have to go back, probably sooner than I should. And maybe I have to hurry because I'm like, oh my gosh, I'm not empty. I got to empty. So it's all about emptying fully so that we don't have to return until, that 2 to 4 hours is up. So yeah, you can still have your elevated toilet seat if that's what you have, but just make sure you have your feet propped up on something. So we'll talk briefly about just environmental modifications to the bathroom, but probably the biggest one is lighting. I have lots of patients who say, well, I had to get up in the middle of the night, but I didn't want to wake, my husband up or whatever, so I didn't turn on the lights, and then I fell. So I usually suggest to have at minimum a night light, or like my bathroom has like you don't even have to turn it on. It has an automatic light. So when you come in, the light comes on, which is really nice because you want to be able to see your surroundings. And then just consider the surfaces in your bathroom, but also on the path to your bathroom. So if you have to go down a hall, what are the surfaces you're walking on? Do you have to go over rugs? Because we know rugs, a little sketchy. Sometimes they can be, put you at risk for falls. Or, do you have that rug maybe that always moves a little bit? Or do you have to go over different terrain? So do you have carpet in your bedroom and then have to go over, go up some stairs or whatever it may be? Just make sure you have, you don't have any fall hazards when it comes to the surfaces or, where are you keeping your bathroom materials really? Is it within reach? Can I reach everything, do it, that I need? It drives me crazy when I go somewhere and I'm sitting on the toilet and the toilet paper holder is like way across the room. I'm like, I can't reach this. So, are you able to modify some of your surfaces to bring everything close to you? And then clutter. I think this is an obvious one, but not just in our bathroom, but the path to the bathroom. So I'm kind of the neat freak, so this totally doesn't affect me. But I will say what does is I consider my cat clutter because I see a lot of people fall over pets on the way to the bathroom. Because every time I want to go to the bathroom, my cat comes with me. I don't know what it is. But just, we can't always minimize that. But, just being aware. I think that's the biggest thing if we can't minimize it. And then last but not least is hand support. So if you are someone who has fallen in the bathroom, do you have railings, that kind of thing, installed? Or if you use an assisted device, like, maybe you typically use a cane. I have plenty of people who say, well, I didn't use one in the middle of the night on the way to the bathroom. And I'm like, why not? So, you may be putting yourself more at risk for falls if you're not using your traditional assisted device. And I know it can get a little tricky because some bathrooms are quite small. So if you use something like a walker, you might not be able to fit that in your bathroom very well, or at least you wouldn't be able to, you might not be able to maneuver it in a way that you normally would. So that may be the case where you do want to talk to a physical therapist and then kind of look at the ergonomics or setup in your bathroom and, see if they have any suggestions. My cat actively tries to trip me. Yes, mine too, especially when I go up and down the stairs. I have 2 cats and they're always under your feet. So it doesn't matter what age you are, the cat or dog is probably going to try to trip you. They're very good at that. All right, so pelvic floor physical therapy, what is it? Because this is really my area of clinical practice, and a lot of people don't even know that pelvic floor physical therapy is a thing. Pelvic floor physical therapy is really very similar to any other physical therapy that you've probably heard of before, except we specialize in really problems related to the lumbo-pelvic region. And pelvic floor physical therapy has really kind of made strides in the last 10 to 20 years. It used to not even be a thing, like not a thing. And then we became really active in helping, postpartum or pregnant patients. And now pelvic floor physical therapy is for anyone of any gender, of any age. This can be from childhood to, my oldest patient in pelvic health has been 92 and she did great. So it's never too late. And we primarily focus on my elevator pitch is that I help people reduce bowel, bladder, or sexual problems. That's really my arena. But pelvic floor physical therapy has been shown to reduce pelvic floor symptoms. So if you have bladder, bowel, sexual dysfunction, decrease the fear of falling and reduce fall risk. So you're like, what does pelvic floor physical therapy look like? You would come into a clinic and you would be evaluated probably very similarly to you maybe have had in the past with orthopedic physical therapy, where I'm probably going to look at your leg strength. I'll look at your abdominal strength. I'll probably watch you move. And then pelvic floor physical therapists specifically are trained in internal, vaginal, and rectal examination. And you're like, what the heck? What we do is we look at your muscle function. So those pictures that I showed you earlier, we're going to assess how strong those muscles are. The muscles that support your sphincters, that support your bowels and your bladder, we need to know how strong they are. And that's not something you have to do if you go to a pelvic floor physical therapist. It's just an option. If you want to know, what's going on with those muscles, do I need to get them stronger? So that being said, you're often going to be given some form of pelvic floor strengthening exercises. And a lot of people say, well, I did Kegels and they didn't help me. And I'm like, well, it's like any other exercise. It has to be very specific. They have to be done correctly, the right number of reps, the right length of holds, the right progression to different body positions. So it's very personalized to you as an individual. And then pelvic floor physical therapists may utilize different tools like pelvic floor biofeedback or electrical stimulation to help you learn how to use those pelvic floor muscles better. And then they can also do things like assist with weight loss. So there's been research to show that decreasing your total body weight by 7 to 10% roughly can have a significant improvement on incontinence symptoms. So if that is something that you need assistance with, we can kind of get you on a strengthening and cardiovascular home exercise program that can help with weight loss and decrease some of your bowel and bladder symptoms. And then last but not least, we are, very well versed in exercise prescriptions. So we, specifically women's health providers, I say women's health because we're really pelvic health, but our certification is women's health. So, again, we treat all genders, but we can help with weight-bearing exercises to improve bone mineral density, which again, we know is important to, decrease the risk of fracture and things like that if you were to have a fall, or teach you how to fall, because there are better ways to fall if we were going to fall. So let's just put it all together here. So based on everything we talked about today, it's very clear through the literature and anecdotally what I've seen as well is that bowel and bladder problems can lead to falls. And unfortunately, those often happen in the bathroom, and they can have some pretty serious side effects like hospitalization and fractures. But the good news is there are a lot of different treatments to reduce bathroom-related falls. A lot of different behavioral changes that we talked about today, they've got really good evidence and they're very successful in helping people manage their bowel and bladder symptoms. But if this seemed a little bit overwhelming, or you're really just not sure exactly where to start with this, the American Physical Therapy Association can help you find a pelvic health physical therapist near you. So if you use this website here, www.aptapelvichealth.org/PT locator, all you have to do is type your either address or zip code, whatever you want to do. You could look in the whole state of Kentucky or wherever you wanted to look, and it will tell you a list of every person who has registered to say they treat pelvic health conditions. So you'll find me if you're on there, but that's just, I send this to people who say, I'm moving out of state. This is nationally. So you can look anywhere in the country you want and find someone and, see where they're practicing. And a lot of times it has their practice details and things like that. So, yeah, so you can find a pelvic health therapist near you. If you have patients that you need to refer to if you're not comfortable treating pelvic health, or if you are a patient yourself who needs needs these services, you can find someone who could treat you. And then I have a lot of references that you don't need to see probably, but if you want them, you really want them, I'll send them to you. But if you do have any questions, we'll go to some Q&A in just a minute. But here is my personal details. This is my work email at Bellarmine, eleve01@bellarmine.edu. I do practice here locally in Louisville. So if you are a Louisville native and need pelvic health services, I'm happy to treat you myself or find someone who would fit your needs. And if you are not local to Louisville and have some questions, feel free to send me an email and I can, try to find some resources for you wherever you are. And I'm happy to do that. So I'm going to stop sharing my screen. Well, I'm going to try. Okay. I think that worked. Not sure where my video went, but that's okay. If anybody has any questions, I'm happy to answer them. If you know you're about to fall, what is the best way to reduce injury? Should you try to fall forward, sideways, or backwards, arms out, or around your head? That's a good question. I would say that answer is twofold, in my opinion. We always want to kind of like tuck our head and almost roll. So a fall on an outstretched arm, like you said, kind of mentioned, arms out, particularly if you have osteoporosis or something like that, you could actually have a wrist or hand fracture. So I don't know if it's like sideways is the right thing. It's more of the kind of cover your head and roll onto your arm. Now, that being said, this is kind of where it's good to have someone practice with you the how do you get up, right? Because you never want to let someone tug and pull on you if you fall into the ground, right? So I try to let like my patients, I make them do it themselves. And it sounds a little bit mean, but some people prefer they have really good hamstring length and they just kind of get into a crouch position and they stand up. But some people need to do like the half kneeling, right? They put one foot up. So I would say try to tuck and roll. And then particularly if you feel like you've been injured, try not to let anyone, I say assist you up, but maybe don't let anybody grab you by the arm and pull you up. I don't know if that's super helpful, but anything else? Roy, I'm not sure if you were chatting, but I think you're muted.
You there?
Yes, we can hear you now.
Okay. Had to hit button a few times. I'm curious, and the contents of your presentation, in particular the falling and so on, do you know of any senior citizen places or other areas for people who are 65 years and older where the information, the best practices, so to speak, from your presentation are promoted? I'm just kind of curious. because I could see how this would help a lot of people, especially the pets angle about being the clutter, and then also just not going to the restroom in the at night, but coming from it as well.
Yeah, I think that's a good question. And I think particularly pelvic health related education is really lacking for the general public. I think PTs, physical therapists are just now getting caught up. So, I don't know if you all kind of saw this, but I'm one of 10 board certified specialists in Kentucky, one of 10. So there's very few people who do this, but the best thing, kind of one of the things I would suggest if you are near the Lexington, Louisville, or perhaps Bowling Green, Cumberland's area is potentially even reach out to some of the physical therapy schools to see if they put on any kind of like programming or anything like that. So at least with Bellarmine, Bellarmine provides a service learning clinic. It's a student run but faculty supervised clinic where every Tuesday, Thursday during the semester, I'm the site coordinator of our Balance and Falls clinic. So if you're looking for like a class, whether it be an exercise class or educational, I mean, honestly, starting at some of the physical therapy programs might be a good start. Um, because I don't know how in depth other community educational I just know how in depth they go.
I was just curious because I know a lot more senior citizens area organizations within the Lexington area are having more seminars, more discussions, more lectures about home safety.
Yeah, I mean, I can't speak too much about the rest of the state. I'm not even as well versed in Louisville as I should be. Bellarmine has something called the Veritas Society, where basically adults, and I don't know the age range, so I apologize, but older adults can sign up to take free courses that they're kind of like educational seminars. And I know last year I did do one on myself and Dennis Lesh here at Bellarmine did one on kind of a like bowel and bladder health,
Mhm.
but so yeah, I think that might be a good start in trying to find some things if you can connect with individuals at the PT programs. But I think it's an area that, needs to be expanded for sure.
Okay. Yeah. Very nice presentation. Thank you so much.
Thank you so much. And I appreciate all of the messages and um, yeah, home safety modification information is out there. Less talked about in the pelvic health perspective. Yeah. I think that, where pelvic health meets fall prevention and fall prevention strategies is we're really just at the tip of the iceberg of what this can look like. So I think we're going to see some new advancements in the next 5 or 10 years for sure.
Good.
All right. Well, thank you all so much for having me. I appreciate it.